Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome back to the channel Standard Medical Notes or lecture. So we are discussing about the topic of hyperthyroidism. Let's move on forwards with the name of Almighty. So coming to the differential diagnosis. The clinical presentation of thyrotoxicosis must be systematically differentiated to ensure accurate therapeutic targeting. Misidentifying the etiology leads to profound management errors. So differentiating hypothyroidism, and in particular it is thyrotoxicosis. So differentiating thyrotoxicosis from non-endocrine mimics. So what should be the approach? So diagnostic approach to patient presenting with severe adrenergic symptoms. So patient presents with severe hyperadrenergic state like tachycardia, tremor, anxiety, diaphoresis, meaning increased sweating, weight loss in spite of intake of food, fatigue. Okay, so these are all symptoms of hyperadrenergic state. Now what you do, you order the initial thyroid function test, that is TSH, free T4 and T3. If TSH is suppressed, then the diagnosis is hyperthyroidism, or you can say it as thyrotoxicosis. Okay, and if TSH is normal, then you consider other diagnosis, that is non-endocrine mimics, rules out thyroid dysfunction. Okay, so there are actually three important things which should be considered if TSH is normal in thyroid function tests. So what are those things? So number one is pheochromocytoma. Okay, adrenal gland tumor. Number two is severe anxiety and panic disorders. Number three is occult malignancies. So these three should be in our mind if thyroid function tests are normal. So let us focus on the key clinical differentiating features. Okay, so in pheochromocytoma there is paroxysmal hypertension, so which is more characteristic. Pheochromocytoma has paroxysmal hypertension, episodic hypertension along with headache and palpitation. So that is a important point, and gland will be normal. So in hyperthyroidism there will be goiter. More than 1/3 of cases they will have goiter. But pheochromocytoma thyroid gland will be normal, and patient will have episodic hypertension. So that is a differentiating clinical feature. And in biochemical findings, thyroid function tests will be normal, but there will be elevated catecholamines, epinephrine and norepinephrine. Or more characteristically, you will measure serum metanephrines or urinary metanephrine levels you will measure. Okay, so that's pheochromocytoma, how you differentiate. In severe anxiety and panic disorders, weight loss is less common, and it is situational often, and it is episodic panic. Okay, so biochemical, if you test, thyroid testing will be normal here also. Okay, again here also thyroid gland will be normal. Occult malignancies, so differentiating features, cancer specific symptoms will be there like night sweats, localized pain. Okay, age of the patient, elderly aged patient, lack of hyperadrenergic features. Okay, so weight loss and fatigue. So that's about the key differentiating features. So what are the symptoms which mimic? Okay, so pheochromocytoma, you will have hyperadrenergic state, paroxysmal hypertension will be there, severe tachycardia. So those all will mimic with pheochromocytoma. Whereas in anxiety disorders, you will have tachycardia, tremor and anxiety. In occult malignancies, patient will have severe weight loss and fatigue, which mimics apathetic hyperthyroidism. But in all these conditions, thyroid function test will be normal. So basically three things we need to non-endocrine mimics we should differentiate. So number one, top list is pheochromocytoma. Number two is anxiety and panic disorders. Number three is occult malignancies. Clinical findings, you will have no thyroid enlargement, no eye disease. Okay, mainly no thyroid enlargement, and thyroid function test will be normal. Okay, that's how you proceed Okay, differential diagnosis. Differential diagnosis is 3 mainly. So from clinical features to diagnosis, how you will move. So this is a flow chart, okay, and instead of taking thyroid function tests, it takes more of it is based more upon the radioactive iodine uptake. Okay, diagnosis is based mainly upon radioactive iodine uptake. Now once you have differentiated thyrotoxicosis from other non-endocrine mimics, now you should identify what is the cause of thyrotoxicosis. That is the second point. So in this flow chart, in this table, what we have done is we have differentiated thyrotoxicosis from other non-endocrine mimics. Now in this second flow chart, we are uh, proceeding for the cause of thyrotoxicosis. We have diagnosed the thyrotoxicosis, but what's the cause? So the causes can be, as you can see, factitious thyrotoxicosis, subacute decurvainous thyroiditis or viral thyroiditis, painless or silent thyroiditis and postpartum thyroiditis. Fourth is Graves' disease and toxic nodular disease. So these are the 4 causes. Again, as I said, so it is because of exogenous iodine, exogenous thyrosin intake, exogenous thyrosin, and these 2 are because of destruction, which causes leakage of T3 and T4, and here there will be increased production. So that's how you need to differentiate. Okay, so let us go one by one. So now when you suspect a thyrotoxicosis in a patient, so you will have TSH less than 0.1 and increased free T4. Now you will see the thyroid gland first, whether the thyroid gland is palpable. Now if it is not palpable, then most probably the diagnosis is factitious thyrotoxicosis. Now what is factitious thyrotoxicosis? The cause is exogenous thyroid hormone ingestion, mainly for weight loss and psychiatric purposes. Features of this is thyrotoxicosis without goiter. There will be no thyroid gland enlargement. But remember, in one cases, even though you don't see any enlargement clinically, you need to rule out the enlargement of thyroid gland by ultrasound also. There can be minimal gland enlargement, which should be ruled out from thyroid gland. Then you can say that it is not thyrotoxic, because many of the times the thyroid gland may be minimally enlarged, and it may be a case of Graves' disease, and we will label it as factitious thyrotoxicosis. So not just clinically ruling out, you should rule out by ultrasonography also the enlargement. So diagnostics, again, you will have suppressed TSH and elevated free T4. Crucial differentiation: there is completely absent radioactive iodine uptake and profoundly suppressed serum thyroglobulin. So this is most important marker of factitious thyrotoxicosis. What is that? Low thyroglobulin levels, low TG levels, low thyroglobulin levels. So low thyroglobulin levels suggest it is a factitious thyrotoxicosis. Okay, so that is another method. So low thyrotoxicosis levels suggest it is a factitious thyrotoxicosis. Now if the thyroid gland is palpable, now you will see the enlarged thyroid gland, whether it is tender or not. Now if it is painful, then most likely the diagnosis is subacute or decurvainous thyroiditis. So it is a destructive thyroiditis. There will be history of viral upper respiratory tract infection usually. There will be painful, tender, firm thyroid gland associated with fever, and in diagnostics, highly elevated ESR and CRP. Distinguishing marker is radioactive iodine uptake is again it is 0, and there will be high inflammatory markers. Okay, because the management is totally different now. Here you will not give antithyroid drugs. Here instead, or radioactive iodine therapy you will not give, or surgery will not do. You will symptomatically you will treat the patient. You will monitor the patient. That is the treatment. That's why knowing is important, the cause. Okay. Now if it is not tender, so I said this flowchart is based upon radioactive iodine uptake. So we will be in the next page we will be seeing flowchart based upon thyroid function test, based upon the thyroid receptor antibodies, radioactive iodine and ultrasonography. So in detail we will see in the next page. Just you see here. So now if the gland is not painful, enlarged thyroid but not painful, so the diagnosis can be 4. So either it can be painless or silent thyroiditis, number 1. Number 2, it can be postpartum thyroiditis. Number 3, it can be Graves' disease. Number 4, it can be toxic nodular disease. So these 4 are the causes of painless enlarged thyroid gland. Now how to differentiate? Now if the radioactive iodine uptake is suppressed, low or absent, then the causes are painless or silent thyroiditis or postpartum thyroiditis. So it is an autoimmune destructive process. It is not viral, it is autoimmune. Okay. Features: this lacks intense pain of subacute decurrence thyroiditis. There will be history of postpartum for postpartum thyroiditis. Diagnostics: so suppressed RAIU, and this is important. Frequently, these type of, because it is an autoimmune process. Again, you should remember, it is an autoimmune process. Painless thyroiditis or postpartum thyroiditis, because it is an autoimmune process. So frequently TPO anti-TPO antibodies will be positive in this case. Okay, anti-TPO antibodies will be positive in this case. Okay, so this type of thyroiditis has triphasic course, meaning first they will have a transient thyrotoxicosis phase, then they will go on to a transient hypothyroid phase, then they will return to the euthyroid phase, and this typically take 3 to 4 months. Okay, after 4 months you just repeat the thyroid function test. So here, because it is an autoimmune process, you will have anti-TPO antibodies. First there will be thyrotoxicosis, then hypothyroid, then patient will return to the euthyroid state. Okay, now if the radioactive iodine uptake is elevated, so either the diagnosis is Graves or toxic nodular disease, nothing but TMNG, toxic multinodular goiter, or toxic adenoma. Now how do you differentiate? So here in the Graves it is typically younger. In TMNG or adenoma, usually seen in older individuals. The gland is diffuse, soft, highly vascular, often with systolic bruit if you auscultate it with your stethoscope. Here the gland is firm, irregular, lumpy gland, and extrathyroidal signs, autoimmune process. Okay, so arboretopathy and dermopathy are frequently present in Graves' disease, but the extrathyroidal signs will be not there in TMNG or adenoma. TRAB serology, thyroid receptor antibody, is frequently present in Graves' disease. Remember to differentiate. Here it is TRAB and here it is anti-TPO here in the postpartum thyroiditis, whereas in Graves it is TRAB, thyroid receptor antibodies. Here it is usually negative in toxic nodular disease. So extrathyroidal signs are not there. TRAB is also negative, and radioactive iodine uptake pattern is diffuse, homogeneous uptake, whereas it is heterogeneous uptake without hot areas or nodules, and suppressed background will be there. So that's how you differentiate. So painless thyroid gland enlargement has 4 causes different, and if it is painful, it is likely subacute decurrence, viral thyroiditis. And if the thyroid gland is not enlarged and then you are having thyrotoxicosis, then it is mostly factitious thyrotoxicosis. Okay, so this is first we have differentiated the thyrotoxicosis from non-endocrine mimics. Then we evaluate for the cause of different type of causes of thyrotoxicosis. So this is the diagnostic approach now, meaning a detailed chart. Okay, a detailed chart now. Diagnostic approach to suspected thyroid function, a sequential algorithm. Suspected thyroid dysfunction, so screening modality, you measure TSH. If TSH is normal, then it is not thyrotoxicosis, no thyrotoxicosis. So thyrotoxicosis is ruled out. But if TSH is suppressed, then measure free T4 or either free or total T3. That is the immediate next step. Okay. Now, if free T4 is elevated, then the diagnosis is overt primary hyperthyroidism, maybe due to Graves' disease or TMNG or toxic nodular disease. The diagnosis is overt primary hyperthyroidism. If free T4 is normal but T3 is elevated, then the diagnosis is T3 toxicosis. Approximately 5% of patients in the early Graves' disease or autonomous nodule So they will have T3 toxicosis in early stage of Graves' disease or early stages of autonomous toxic nodule. So absolute requirement to measure T3 if TSH is suppressed but free T4 is normal. Yeah, this is the absolute requirement. So measure T3 if TSH is suppressed and T4 is normal, then you should measure T3, free T3. Okay, free T3 you should measure. If their TSH is suppressed and free T4 is normal, then that means maybe the hyperthyroidism can be in the early stage, or maybe it can be subclinical hyperthyroidism. So you should also measure free T3 also. Okay, now if both free T3 and T4 are normal, both should be normal. Okay, not only one, both if they are normal, then you will give a diagnosis of subclinical hyperthyroidism. But if you have T3 raised, that is T3 thyrotoxicosis. T4 and T3 both raised, then again it is overt hyperthyroidism. T4 raised, again it is overt hyperthyroidism. Okay, both T3 and T4 normal, free T3 and T4, then it is subclinical thyrotoxicosis. Now you have diagnosed the thyrotoxicosis. Now you will evaluate for different causes of thyrotoxicosis. Now one point to remember here is post-therapy TSH re-equilibrium lag. TSH profoundly suppressed for 4 to 8 weeks after free T4 and T3 normalize. Never adjust the drug dosages based on TSH in first 2 months. Monitor efficacy via free T4 and T3 trends. That is very important point. Why? Because in hypothyroidism, we see the levels of TSH and we monitor the T4 T3 dose. But in hyperthyroidism, we should not monitor the drug doses based upon TSH, because TSH will take 2 months approximately to normalize. That's why we should monitor based upon the levels of T4, T3 mainly T4, free T4. Okay, now you will evaluate for the cause of your thyrotoxicosis or hyperthyroidism. Sorry, not thyroid. So you have diagnosed thyrotoxicosis. Now you evaluate for thyrotoxic, cause of hyperthyroidism. So you will not say it as hyperthyroidism, you will say thyrotoxicosis only. Okay, so evaluate for classical Graves signs now. So you are saying for Graves signs, whether there is moderate to severe orbitopathy or not, whether there is a large diffuse goiter thyroid buoy or not. If yes, then the diagnosis is established clinically and no advanced imaging is needed. What is that? That is Graves' disease. Okay, so from thyroid function test you are going clinically here. There in the first chart you came clinically, then to the thyroid function test, but that was based mainly upon radioactive iodine test. But if no, there is no thyroid gland enlargement, there is no thyroid eye disease, then further evaluation is required. So investigations for etiology, number 1 is measure TRAB, thyroid receptor antibody. If they are positive, then it is a Graves' disease. If they are negative or unavailable, then you can proceed for the third step, that is radioactive iodine uptake or ultrasonography. Perform radioactive iodine uptake scan by utilizing iodine 123 or technetium 99M. Okay, if it is diffusely elevated uptake, then it is Graves' disease. If focally elevated uptake with suppression of surrounding gland, then it is toxic adenoma or toxic multinodular goiter. If low or absent uptake less than 5%, that means what? That means now you are not having any thyroid gland enlargement also. It's clinically. That means if low or absent uptake on radioactive iodine, so first we are excluding here Graves' disease, then we are coming to toxic nodular goiter, or it can be painless thyroiditis, but or postpartum thyroiditis, or it can be viral thyroiditis also. But there also you will have enlarged thyroid gland, but clinically you are not having. So if it is low or absent uptake, that means it is destructive thyroiditis. So the causes can be 3 now. What are the 3 causes? The 3 causes are, number 1 is subacute decure veins, that is the first cause, thyroiditis. Okay, number 2 is a painless or postpartum thyroiditis. So painless thyroiditis, or third one is postpartum thyroiditis. Okay, so these 3 you should rule out. How you will rule out? Now you will do ultrasonography. Okay, you will perform ultrasonography now. Definitely rules out hyperthyroidism and considers destructive thyroiditis, exogenous hormone injection and iodine load. Now thyroid ultrasonography with color flow Doppler. alternative if radioactive iodine is contraindicated, for example in pregnancy. So ultrasonography with color flow dropper you can use when there is low iodine uptake, or it is an alternative, or when this radioactive iodine uptake is contraindicated, for example in pregnancy, there you can use this ultrasonography with color dropper. Markedly increased or diffuse vascularity signifies Graves' disease. Decreased or absent blood flow signifies destructive thyroiditis. Okay. Now again here, high dose biotin, vitamin B7 interference. Biotin supplements interfere with streptavidin biotin technology in automated assays, result falsely low TSH and falsely high free T4 and T3, perfectly mimicking primary hyperthyroidism. So instructions: withhold biotin for at least 3 days prior to testing. So biotin interference you should remember. Okay. Now just to conclude this diagnostic part. So first what we are doing is we are confirming whether it is thyrotoxicosis versus non-endocrine mimics. So once you have diagnosed that is thyrotoxicosis, then you are evaluating for the cause. Causes can be broadly divided into 3. Okay. Either it can be increased production, okay, or it can be exogenous administration, or it can be leakage. In production, number 1 is Graves, number 2 is toxic MNG. Exogenous administration, patient will take by mouth, mainly for losing weight. And in leakage there are 3. Number 1 is subacute thyroiditis, number 2 is painless thyroiditis, number 3 is postpartum. Okay. So in history, in Graves' disease you will have a diffuse enlargement of thyroid gland which is painless. In toxic MNG you will have enlargement of the thyroid gland which is painless, but it is not homogeneously enlarged, it is heterogeneously enlarged. In exogenous you will not have any enlargement of thyroid gland, and you will not have any enlargement. Whereas in subacute viral thyroiditis you will have painful enlargement of thyroid gland, history of fever, history of upper respiratory tract infection. And in painless or in painless thyroiditis you will have enlargement of thyroid gland, but there will be no pain, and there will be no history of purpurium. But in postpartum you will have history of pregnancy. So that's how you differentiate clinically. Now that's one thing. Now for Graves, number 1 part is the Graves and toxic MNG. What you will do, I think you will do is, for Graves you have TRAB measurement. Okay, TRAB, thyroid antibodies. If these are positive, then Graves disease is confirmed. For toxic MNG, ultrasonography you can do, and you will know that it is toxic MNG. Now the exogenous, in exogenous one thing, so in exogenous one thing you will do, that is thyroglobulin level will be increased. Okay, TSH will be suppressed again, and there will be increased free T3 and T4 in exogenous. But this point is one, increased thyroglobulin level. And in subacute thyroiditis, so in subacute, so here inflammatory markers will be increased. Like increased ESR, CRP will be there, and if you are doing radioactive iodine, suppressed, that is suppressed. For painless thyroiditis or postpartum thyroiditis, here you will have autoimmune bodies, so anti-TPO antibodies will be present, and these two will have a triphasic course. First thyrotoxicosis, then hypothyroidism, then euthyroid state. So that's all about the evaluation of thyrotoxicosis. So these both four charts are important. You can remember these both. Okay. So 3 things, basic things important, that is whether it is due to excessive production or due to leakage or due to exogenous. Okay. Now this is the management. Oh, I think it will take one more video to complete this. So coming to the management strategy now. for hyperthyroidism. Remember, whenever I say hyperthyroidism, that means there is increased production either to Graves or due to MNG, toxic MNG. Whenever I say hyperthyroidism, I mean this one. Okay. So management strategies, according to the American Thyroid Association 2016 or European Thyroid Association 2018 guidelines, first initial assessment and first symptom control is important, acute symptom control. So first you mitigate the adrenergic drive. How you give the beta blockers? Preferred choice is propranolol, immediate release. High doses up to more than 160 mg per day can be given. This controls symptoms like tachycardia, tremor, and uniquely it inhibits 5-monodeiodinase enzyme, reducing peripheral conversion of T4 to T3 also, this propranolol. Okay. Up to more than 60 mg per day you can use the dose of this propranolol depending on the symptoms of the patient. Now, if it is contraindicated, for example, in case of asthma or COPD, propranolol is contraindicated. Okay. So there you can use cardioselective long-acting beta blockers like metoprolol or metoprolol. Now again, if beta blockers, all the beta blockers are contraindicated, then you can use alternatively like non-dihydropyridine calcium channel blockers like verapamil, diltiazem for when there is beta blocker contraindication. That is, you are controlling symptoms first. Then secondly, what you are giving is you will give anti-thyroid drugs. So there are two types of anti-thyroid drugs mainly. So these are also known as thionamides. Okay. So one is methimazole and the second is propyl thiouracil. So methimazole is universal first line agent. It is a long acting agent, so once daily dosing is enough. Mechanism of action is it inhibits thyroid peroxidase. So where it is used for Graves' disease, induction of remission induction, peripheral blockage, that is conversion of T4 to T3. So this action is not there in methimazole. The risk of hepatotoxicity is less in methimazole. But the peripheral conversion is not there. Long acting, okay, for Graves' disease induction, not for Graves' disease induction. Okay. Now coming to propyl thiouracil. So it is a second line agent for hyperthyroidism, reserved. So because the half-life is short, it requires multiple dosing. Again, it will inhibit the TPO enzyme. Okay. So mainly this is used in first trimester of pregnancy where methimazole is contraindicated. So one point to say, so there was a drug also known as the brother of this methimazole, that is carbimazole, which was used previously till now very much. But nowadays physicians are preferring and switching onto methimazole, and guidelines are also suggesting methimazole because it has less toxicity when compared to methimazole. So that's why we are discussing methimazole only. So propyl thiouracil. So first trimester of pregnancy, propyl thiouracil is the drug of choice, and this methimazole is contraindicated. In Thyroid Storm, so propyl thiouracil is used, and whenever there is methimazole allergy, you can use this propyl thiouracil. So peripheral blockage is complete with propyl thiouracil at high doses. So that's why it is useful in Thyroid Storm. But one major drawback is it has a high chance of fulminant hepatocellular necrosis. So this is a FDA black box warning. High chances of hepatotoxicity. You should monitor the liver function tests. So here three things. It is used in first trimester of pregnancy, it is used in Thyroid Storm, and it is used in methimazole allergy. Here it is only one, Graves' disease. And one more thing, after first trimester of pregnancy, in the second and third trimester, you can use methimazole. You switch on to methimazole from propyl thiouracil. Okay, only in the first trimester the methimazole is contraindicated. That's all. Now there are two methods of using this anti-thyroid drugs, or you can say more commonly this methimazole. The first method is the titration method. The second method is the block and replace method. So in titration method, which is preferred by European Thyroid Association and which is the commonly practiced, so that is this. So you will start with a high dose of the drug. Commonly this methimazole is 20 to 30 mg dose. It is used in the divided doses. Okay. So start with high dose, and whenever and after 1 month you will see the free T4 levels, free T4 T3 levels. Then according to that you will titrate the initial induction dose. That is the one method. The second method is you will totally block the thyroid gland. Constantly you will give high anti-thyroid dose along with levothyroxine. So that's what are you doing is you are taking the function of thyroid on your hand. So by stopping the gland from producing this thyroxine and giving the thyroxine from outside. So that is block and replace method. consistent high ATD dose method plus levothyroxine. So these are the two methods of giving the drugs. Okay. Now, one thing to remember is approximately 40 to 50% cases of Graves' disease will go into remission in 1 year. So what is the importance of that? You stop these thionamides after 1 year. So 50% of the patients will remit and 50% of the patients will the disease will relapse. So in those cases where the disease relapses, then you can plan for radioactive iodine or surgery of the thyroid gland there. Or if the patient is not allowing for radioactive iodine therapy or surgery, he is not allowing the doctor to do those things, then you can continue thionamides itself by monitoring the hepatic function tests. So that's the protocol of management. Okay. So these are management strategy of hyperthyroidism. Now definitive therapy are two things. One is radioactive iodine and the second one is surgical management. Now you have given the thionamides to the patient. Okay. Now radioactive iodine therapy. What is the mechanism? So because it is a iodine, it is taken by the sodium iodide importer into the cells. So this iodine will emit high energy beta particles, cause severe DNA damage, localized cellular necrosis, progressive glandular fibrosis. So that's the mechanism. What is the indication? Indication is mainly toxic adenoma or toxic multinodular goiter where it is referred. So radioactive iodine is mainly used in toxic multinodular goiter or toxic adenoma. There it is preferred. And second indication is the outcome of Graves' disease. I said 50% of the patients will remit and 50% of the patient will relapse. So either you can use primarily also, meaning without giving thionamides, directly you give radioactive iodine, meaning after controlling the disease with thionamides, you will after some after 1 to 2 months, when the thyroid hormones comes to normal, you will give radioactive therapy. That is primary. Relapse is when you stop the drugs after 1 year and 50% of the patients will relapse, then in that case you will give radioactive therapy. Now one important point is, after giving radioactive therapy in Graves' disease in hyperthyroidism patient, there will be inevitable permanent hypothyroidism, and that's why up to 80% of Graves' disease patient will require exogenous levothyroxine therapy within the first year. 80% of the patients, remember. That means a patient who has undergone who has taken radioactive iodine therapy should be monitored either for Graves' disease or toxic multinodular goiter. So they should be monitored for every 3 monthly for hypothyroidism, because 80% of the patient will require levothyroxine therapy in the first year itself. Okay. Now, what are the contraindications of radioactive therapy? So absolute contraindications are pregnancy and lactation. So there is a risk of fetal hypothyroidism, that's why. And active, moderate to severe Graves' orbitopathy. This is also a very important thing. Active eye disease, and that to moderate to severe Graves' disease. Active, moderate to severe Graves' disease is a contraindication for radioactive iodine therapy. So warning box, orbitopathy flare. So radiation induced stored thyroid antigens release, so that will cause autoimmune exacerbation. What that means is, so when this radioactive iodine kills the cells, so the cells, the particles of the cells will get released in the circulation, so they will be recognized as antigens by the body's immune system, and there will be exacerbation of autoimmune destruction. So that's why there will be orbitopathy flare in these patients. Okay, that's why you should not use in patients with moderate to severe eye disease, active eye disease, so radioactive iodine therapy. So what is the solution for that? If you have given, so in mild eye disease, you can for mild eye disease, one can plan for this radioactive iodine therapy. So provided the patient should be mandatorily given concurrent prophylactic corticosteroid therapy, pulse therapy in the form of pills like methylprednisolone 500 mg once daily for 3 days, like that. In mild eye disease, I am saying mild eye disease along with glucocorticoids, one can undergo radioactive iodine therapy. But in case of active, moderate to severe orbitopathy, you should not give this therapy. You can plan for surgery along with antithyroid drugs. So that's the thing. So next thing is surgical management. Thyroidectomy, meaning removing the thyroid gland. Okay. So what are the indications? So if the gland is massive obstructive goiter with compelling symptoms, like if the patient is having dysphagia, stridor, venous engorgement, then that is an indication. So if you are suspecting malignancy in the enlarged gland, then that is also indication. Severe active orbitopathy, as we have discussed, in moderate to severe disease you can't give radioactive iodine. So in that moderate to active disease, so you need to do surgery. Okay, how that surgery is done, so that is also we will learn that what pre-operative precautions we should take. So severe active orbitopathy is an indication for Graves' disease surgery. Or if the patient is refusing to take, or if any contraindication is there for anti-thyroid drugs and radioactive iodine like pregnancy, so there you can plan for surgery. So in surgery, critical point is pre-operative preparation of the patient for surgery. So pre-operative optimization surgery. So number one, what you should do, you should first achieve complete euthyroidism using the anti-thyroid drugs to prevent thyroid storm. Why? Because when you are cutting the thyroid gland, so through your knife, so you are spilling more and more T3 and T4 into the circulation. So that will cause that may cause thyrotoxic crisis. So that's why you should before going on to surgery, patient should be stabilized on thionamides or anti-thyroid drugs. The second thing is pharmacological potassium iodide, saturated Lugol's iodine for 7 to 10 days immediately before surgery. So one point to remember is this potassium iodide should only be given after anti-thyroid drugs have brought down the thyrotoxicosis. Okay, because what is the main purpose of giving potassium iodide? So to prevent leakage is the purpose. So if you are not giving ATDs, so there is increased production, and when you are giving potassium iodide, so the gland is active and it will utilize this iodine and there is a risk of thyrotoxic crisis. That's why you should not give potassium iodide before giving anti-thyroid drugs. So you will give after ATDs 7 to 10 days immediately before surgery. So what will happen with this? Wolff-Chaikoff effect will take on. So that drastically reduces the vascularity and friability of hyperplastic gland. So that will minimize hemorrhage, and that will minimize hemorrhage. Okay. So some complications of surgery. So you know, if you the anatomy of the thyroid gland, just behind the thyroid gland there is parathyroid gland. So maybe the surgeon may remove the parathyroid gland along with thyroid gland by mistake. So that will lead to parathyroid resection, and patient will have permanent hypocalcemia because of decreased PTH, parathyroid hormone. Okay, lifelong calcium you should give to the patient. Or because there is recurrent laryngeal nerves which are going through the thyroid gland, so there can be damage to those nerves leading to hoarseness of the voice or respiratory compromise. Okay, so these are the two important things which can happen. So the parathyroid gland can be damaged or the recurrent laryngeal nerve can be damaged. So that was all about the radioactive iodine. What are the contraindications, what are the indications, surgery, what are the indications of surgery, and what are the pre-operative preparation for surgery. So everything we have learned. Now we will finish this thyroid storm and we will stop. So management of thyroid storm, an orchestrated intensive care approach. So classically, by sequence we manage the thyroid storm. So you can remember it by 5 B's. So thyroid storm requires a multimodal ICU approach designed to immediately block sequential steps of the thyroid hormone synthesis and metabolic pathways. So first what we will do, we will block the synthesis. Next we will block the release. Next we will block the conversion in the circulation of T4 to T3. Then we will use beta blockers to control the adrenergic drive. Then lastly what we will do is, so fourth is beta blockers, fifth is bring down fever and provide the supportive care. Beta blockers and bring down fever and provide supportive care. So these are the 5 steps, 5 B's. Number 1 B, block synthesis. Give high dose ATDs. Administer, so as you have learned, propyl thiouracil is the drug of choice in case of thyroid storm. So administer high dose propyl thiouracil 200 to 400 mg every 6 to 8 hours. Why? Dual action, it inhibits synthesis and peripheral T4 to T3 conversion. Now one thing, wait for 1 hour. This timing is critical. Why? Clinical pitfall, iodide timing. Administer at least 1 hour. This pharmacological iodine should be administered at least 1 hour after the ATD loading dose. Why? Premature administration allows unblocked hyperactive gland to utilize substrate, synthesize and release massive amounts of new hormone, catastrophically worsening the storm. So Wolff-Chaikoff effect will be Wolff-Chaikoff, as I said before. So this hyperactive gland has lost his Wolff-Chaikoff effect. So that's why you should give thionamides, and then you should give the iodine, either in the form of Lugol's iodine or potassium iodide. Then it will block the secretion of this. So at least 1 hour gap should be there. 1 hour gap. Okay. Then you are blocking the release pharmacology. So you are giving Lugol's solution or SSKI to exploit the Wolff-Chaikoff effect, abruptly halting the release of preformed colite. Okay, that's one thing. Then block the T4 to T3 conversion. How? By giving IV glucocorticoids. Administer IV glucocorticoids. Example, hydrocortisone 100 mg every 8 hourly, or dexamethasone, the dose is 2 mg every 6 hourly. This will potentially inhibit peripheral deiodination and provide coverage for relative adrenal insufficiency, as severe hypermetabolism rapidly depletes the cortisol reserves. Otherwise, the patient will end up in adrenal crisis. So the block T4 to T3 conversion by giving glucocorticoids. Number 4 is beta blockers. Utilize IV, or if IV not available, high dose oral propanol. So up to more than 160 mg you can give immediate release. Okay. Gain rapid control over life-threatening tachycardia, arrhythmias, and extreme sympathetic agitation. Then fifth is bring down fever and provide supportive care. Aggressive external cooling measures. So in hypothyroidism, passive heating was the thing. Here you can give active cooling, like cooling blankets you can give. And because of there will be fluid loss, so fluid resuscitation to combat severe insensible losses, and broad spectrum antibiotics for underlying infectious precipitant. So bring down the fever and provide supportive care. So 3 things you are going to do. So one thing is you are bringing down the temperature by cooling blankets. Second is you are providing IV fluids, and third is you are giving antibiotics and IV fluids. Okay. Bring down fever, clinical pitfall. Strictly, this is a very important point again. So in hyperthyroidism or thyrotoxicosis or Thyroid Storm, strictly avoid aspirin for antipyresis. Why? Salicylates competitively displace T4 from thyroid binding globulin, raising the free hormone level. That's why paracetamol or acetaminophen is the drug of choice for controlling fever in patients with Thyroid Storm or Thyrotoxicosis. So NSAIDs or aspirin should not be used. Why? Because they will displace the bound T4 to the TBG, and they will increase the levels of free T4, again worsening the thyrotoxicosis or Thyroid Storm. Okay, that's about the management of Thyroid Storm. 5 B's: block synthesis, block secretion, block peripheral conversion, and beta blockers, and bring down fever and supportive measures. Now we will see the management of Thyroid Eye Disease. Conservative, modern, targeted approaches. So it is different for mild, moderate, and severe. So for mild disease, mild symptoms like minimal proptosis and the patient has clear eyes, there is no redness. Okay, you will have this conservative management. So you will give artificial tears, dark glasses, and strict smoking cessation. Remember, smoking is a very bad thing in patients with thyroid eye disease. It will exacerbate the eye disease, smoking. So artificial tears, dark glasses, and strict smoking cessation. This is the thing for mild thyroid eye disease. Okay. Now for severe thyroid eye disease, by severe eye disease mean there should be a compression of optic nerve and threatening of the vision of the patient. Here, aggressive care in severe vision threatening thyroid eye disease. So one clue for this is pretibial mixed edema. So that points that the thyroid eye disease is severe. Okay. So what you will do, you will give high dose IV pulse methylprednisolone like 500 mg once daily for 3 days. That is one thing. Second thing is orbital radiotherapy you can plan, or third thing is surgical orbital decompression you can do. Okay, these are the 3 things: IV methylprednisolone, orbital radiotherapy, or surgical orbital decompression when the nerve is compressed. Now this is for active moderate, targeted therapy for active moderate to severe disease. One point to remember is, if you are, as we have discussed, if one is undergoing for a radioactive iodine therapy for this hyperthyroidism and Graves' eye disease there, so radioactive iodine therapy is absolutely contraindicated in active moderate to severe disease. But for mild disease, you can use radioactive iodine therapy concurrently with glucocorticoids. That is the one thing. Okay. So for moderate to severe thyroid eye disease, you can use one drug that is known as tiprotumab. Tiprotumumab. Okay. What is the mechanism of action? Target is the insulin-like growth factor IGF-1 receptor blockage. So what will happen? Prevents IGF-1 and TSH receptor crosstalk. What is this crosstalk? So remember, when the thyroid receptor antibodies are acting on the thyroid TSH receptor, they are giving information to the IGF-1 receptor as well. They are stimulating the IGF receptor also collaterally. That is known as crosstalk. Okay. So this IGF-1, what it will do is it will stimulate the fibroblast, and fibroblast will secrete the glycosaminoglycans, and that will cause swelling and adipogenesis and muscle disease, all those things. So when you are blocking this IGF-1 receptor, so this crosstalk is blocked. Now this will reduce the thyroid stimulating immunoglobulin. This will halt the fibroblastic signaling cascade. So decreased glycosaminoglycan production, reduced adipogenesis, diminished orbital muscle volume. So reduced proptosis, reduced diplopia. So how you will administer this tiprotumumab? So it is a 21-week course. Every 3 weeks you should given. Up to 8 infusions should be given. So every 3 weeks, meaning 21 days for 8 infusions. Okay, that is how you give. So the marker for moderate to severe disease is prominent proptosis, red eyes, double vision, diplopia, but there will be no optic nerve compression. So if there is optic nerve compression, then that is classified as severe disease. Remember, and for severe disease the management is different. For moderate to severe disease, it is tiprotumumab. For mild disease, it is different. So that's about the management of thyroid eye disease, and I think it is enough. We will discuss further topic which is remaining in the coming video. So it is a little bit lengthy topic. It needs some time. Okay. Thank you.